Well, thanks very much for logging into YouTube and watching this video. We're hopeful that this is going to be a helpful way for you to get to a better level of understanding of the changes that are happening here at Skiff right now. And what I'd like to do is start off with why we're making changes. And the big reason here is that we went through a strategic planning process. And we know that we have one overarching aim. And that aim has to be that this hospital is here. And you probably know that we've had several years where we've had negative financial margins. And there's a number of reasons for that, with the closing of Maytag and the recession and a number of different things. Healthcare reform has been both helpful and harmful in different ways. But what we do know is that we are being saved right now by healthcare reform because there's extra money coming in from the government. And because of that, we have to adapt ourselves to the way that we are paid. And the government with healthcare reform has one paragraph, and it's called the Rural Community Hospital Demonstration Program. It changes the way that we provide inpatient care because we revert back to the payment mechanisms of 1982. Basically what it does is it pays us the actual cost for taking care of an inpatient that's covered by Medicare. And in fact, it pays us the same for a skilled nursing patient as it does for an acute care inpatient. We are thrilled at this because we have a lot of people in our town that really need longer lengths of stay in the hospital and need skilled nursing care after their hospital stay. In the past, we were not able to provide that due to the way that the government reimbursed us, but now we can, and it's a wonderful opportunity. Now, the interesting thing that's happened is in the last several weeks, we have actually had a couple of peaks in the number of patients staying with us, and we actually had our highest census in many years about 3 or 4 weeks ago. In fact, our hospital has 48 rooms, so we have 48 beds. And we ran out of space. In fact, we were looking for space for our last patient to be admitted. Now, that same night when we were out of space in our inpatient units, there were 5 empty rooms on the Monarch wing. Now, the reason there were 5 empty rooms is because our census has been going down in our hospice program for quite some time. And that unit is designated as a hospice house by the state. That means only hospice patients can be admitted there. Now, that space used to be our OB unit. So there's a number of wonderful stories of folks that have delivered babies here in town up in that unit and then have used it for its hospice function. So the problem is that we have empty space quite often because our census has been going down in hospice. That's because we have a lot more competitors in town. We have Hospice of Central Iowa and Iowa Hospice. One of the local nursing homes is about to open a hospice as well. That particular nursing home accounts for 15% of our hospice volume. So we know that downward trend is going to continue into the future. So we have these two needs. On the one hand, we need more space. We have 48 rooms, and we were up to 42 patients, which left 6 rooms, and those were designated to hospice. So we've had to take a hard look at our hospice program. And you know, we started comparing ourselves to other hospice programs nationally, and what we found is that 80% of patients in hospice programs across the country choose to pass away at home. And that makes sense because the whole hospice concept was developed so that we could have a process whereby folks at the end of their life could have high quality of care and quality of life during those final days and weeks. And then we could focus on the needs of the family at the same time. But 80% of patients nationally choose to pass away at home. But we looked at what we do here in our hospice program, and even though we have a pretty low census, we have about 15 to 17 patients at any given time, what we found is that most of the care we provide is at home as well. But 80% of our patients actually pass away in our Monarch wing. Even though we have a census right now of about 2 on average. Certainly sometimes it's higher, many times it's lower, in fact it's often closed. So we looked at that, and we also then looked at our operational statistics, and we found that 80% of all the revenue that comes into our hospice program comes from what we do in a patient's home. And 80% of our cost comes from the Monarch wing because the cost of staffing is quite high. So we look at all of this together, and we even add in the gifts that are given to hospice program, which by the way is they're given every year through memorials. They flow right into the hospice department. But what we've seen is this trend where the revenue into the hospice department plus all of the gifts are not covering the expenses, and that gap is getting bigger and bigger. And the hospital supports that gap, and we can't afford to do that. So as we move into the future, we have a number of things that are happening here. On the one hand, we're having more and more inpatients that will be admitted to us. On the other hand, we'll have fewer and fewer hospice patients that will be admitted. And we've had to make a decision, and it's not an easy decision, it's a hard decision. But it's a decision that allows us to keep our hospice program whole, and hospice patients will continue to be admitted to the Monarch wing. And let me stop for a moment and just say, the Monarch wing is not closing. The hospice program is not closing. hospice patients will continue to be admitted on the Monarch wing, but there will be changes. We are taking the Monarch wing and we will not designate it as a hospice house officially from the state. It will become part of our inpatient bed capacity, so we'll have 48 inpatient beds. The Monarch wing staff are these extraordinary caregivers that have this phenomenal wealth of experience with end-of-life care and dealing with patients and families in very difficult circumstances. They're going to be folded into our inpatient nursing department, and they're going to bring that experience with them, and we're going to have a better department at the end. That means that the space up on the Monarch wing, while it will continue to be used to house hospice patients when needed, will also house other patients, low acuity inpatients. Now the hospice wing itself is not going to change. The decor will not change. The way it looks is not going to change. We are going to do some work inside the walls though. We have to wire for our electronic health record, for our nurse call system, for telemetry, so that we can treat a wider variety of patients there. But I'm actually very happy that we're going to be able to open that wing for more families and more patients to enjoy that extraordinary resource that we have. So let me be clear, Monarch is not closing, hospice is not closing. Hospice patients will continue to be admitted on the Monarch wing, but things will be different. The nursing staff will be consolidated with inpatient, and that unit will be opened up for other patients to be admitted there. Now this is a hard decision for us, because it's very emotional for our community as well. There was a very large fundraising campaign back in 2004. In fact, that unit cost $3.5 million to renovate. There was $1 million that was given from the community. About half of that was from the Maytag Family Foundation. And about 800 people gave the other $500,000. It was an extraordinary gift. The other $2.5 million was supported out of hospital funds. We want everyone to know that we value our hospice program. It is an extraordinary program for us. And it will still be here, but it will be different. This is our way of making sure that we can continue to offer those services. Now there are a number of questions that have been asked. I want to just read through a few of those and try to clarify things. First question that many people ask is Skiff Hospice closing? The answer is no, it's not closing. Is the Monarch wing closing? Well, no, once again, it is not closing. Why is this change necessary? Well, frankly, because of the way that Medicare has chosen to pay us, which is a good thing. We're going to have more inpatients, we need that space, and the hospice census has been declining. Census is so low because of competition and the desire of patients to pass away in their own homes if possible. What is the Rural Demonstration Project and how does it impact hospice? We are one of 26 hospitals nationally that were chosen to be in a demonstration project for Medicare that was part of healthcare reform. We are paid based on the cost of providing services. Prior to this demonstration program, which started in July of 2011, we were actually paid 89 cents for every dollar it actually cost to take care of a Medicare inpatient on the inpatient side. Now we're paid cost, and that is a huge impact on us. It also means that we will have more patients because we can care for more patients. Will there be construction? I think we've answered that. It'll be behind the walls. Are the family facilities like the laundry, kitchen, reflection room being removed? The answer is no. In fact, those rooms will be helpful for all the patients that we might have there, especially those that are in that skilled nursing and rehabilitation phase, because they need to have that kind of equipment for their rehabilitation. If a hospice patient needs to be hospitalized, well, where will they be placed in the future? Well, you know, historically we have used the Monarch wing, and we have every reason to believe that that's what we will continue to use. But we will base placement based on the needs of the patient and the family. One of the side benefits of this is that we have extraordinary spaces on Med-Surg and then on our Med-Surg West unit that some patients might find more comfortable. So we're not limited now to just the Monarch wing. We can use all of those spaces. And here's the last question. Are Med-Surg nurses qualified to take care of hospice patients? Well, you know, our Med-Surg nurses take care of very high acuity patients, very low acuity patients, and it might surprise you that there are probably almost as many patients who pass away on the inpatient wards that are not in the hospice program as those that are in the hospice program. What we're going to have with a consolidated hospice and inpatient nursing cadre is people that are very good not only at those higher acuity cares, but at dealing with patients and families at the end of life, and I think we're going to be able to offer a better level of care overall. Finally, will hospice patients receive their same great care? Absolutely. At Skiff Medical Center, we want you to get your care because the best care is close to home, and that does not change. And I'll tell you, this is an emotional issue, it really is. And folks are very passionate about this, and I am very happy that they are, because their passion shows me that they care about what we do. And I love the fact that they really do desire to have our hospital here and they want it to be the best. So things will be different, but they will be as good and possibly better in the future. Thank you very much.